And we've also heard about, there's a good discussion, bendamustine rituximab, single agent rituximab, chemoimmunotherapy, different choices. We have seen some new data out about, or recent data about the GALLIUM study with the incorporation of obinutuzumab in chemotherapy. John, what do you think about that? I mean, is that something you do every day? What's your take on the data?
Well, the GALLIUM trial was a very positive study, and if you remember, it was essentially a chemotherapy choice between BR, R-CHOP, or RCVP, either with rituximab or with obinutuzumab, and then there's some maintenance. And clearly it was shown that progression-free survival was significantly better with the obinutuzumab containing regimens and maintenance therapy compared to rituximab, the rituximab arm. But there were two major things to take away from that outside of that. One was that there was no difference in overall survival. And the other was that there was a lot more adverse events and toxicity with the obinutuzumab. And in particular, there were concerns about infections and, of course, some infusional toxicities. So for me, at the end of the day, this didn't change practice. And I think it didn't change practice for many of us. I think rituximab still remains the primary anti-CD20 antibody that I'll use in the frontline setting, despite this positive randomized 3 data. Again, no difference in overall survival, and adverse events are not quite as good with obinutuzumab as they are with rituximab.
I mean, I think that brings up an interesting point about progression-free survival as an endpoint in follicular lymphoma, and practically it's really the only thing that can be done. But we've seen a number of studies, peer-reviewed, that there's an improvement in progression-free survival. Everyone assumes that then you take that approach, it's going to be a better in overall survival. But so far, that really hasn't panned out.
Yeah, I came back to in our institution we are using frontline bendamustine plus rituximab, and I totally agree with my colleagues that with the advent of GALLIUM. So GALLIUM is a positive trial, but at the end of the day, the inclusion of obinutuzumab is a little bit more toxic than rituximab, and there are no difference in terms of overall survival. And at the end of the day, this is a real endpoint, primary endpoint for indolent disease like follicular lymphoma. And for this reason, we decide to use obinutuzumab in combination with the bendamustine in frontline only for a really selected subset of patients, in particular high-risk FLIPI, because there was a demonstration that there is an increase of the overall response rate and CR rate, and could be important this selected patient to increase this kind of result. But at the end of the day, so it's so difficult to change the role of rituximab in frontline treatment or in combination with conventional chemotherapy, not only in frontline but also in second line, third line, because it's very active and is less toxic when you compare with obinutuzumab. And for the patient, it's very important at the end of the day. So the progression-free survival was better using obinutuzumab containing regimen, but it's not the real primary endpoint for the patient and, of course, for the doctors.
Matt, we're looking for better response criteria, better endpoints in some of these studies. Chronic lymphocytic leukemia, it's becoming very commonplace to look at MRD testing as a surrogate for the depth of remission and how long someone's going to reign remission. I think in some studies even overall survival. But in follicular lymphoma, it's not, I mean, some of the studies show it, but we're not really using that in clinical practice, right?
Yeah, so in the GALLIUM trial, they did look at MRD, and there was, I think, more MRD negativity in the obinutuzumab chemo arm. I can't use that in practice. I think what GALLIUM has done for me when I'm having a discussion with the patient is it's made the conversation or the discussion longer. Because I feel like I'm obligated to have the GALLIUM discussion in a person that I think could tolerate obinutuzumab. Like Dr. Zanzani, perhaps the high IPI, the young, fit individual, if you explain to them that this may prolong your progression-free survival against a different antibody, but there may be some upfront cost to that. I think what MRD could do is risk adapt follicular lymphoma. So if you can show that the infections were due to prolonged maintenance, or that maybe you didn't need as long of therapy based upon MRD negativity, if that is shown to bear out over time for PFS, that may be the utility of MRD, but I can't do it in my clinic today.
Yeah, I would agree in that, and just want to reiterate and stress that we don't have a role for MRD testing in follicular lymphoma at this point. It's not a routine test that should be done because it doesn't change practice for us. I agree.